Ladies and gentlemen, distinguished chairs, I'm honored to speak today, and especially like to thank the organizers and Zaza for inviting me to talk about what I think is a very novel and important topic. You recognize this verse from Amos, should two walk together except they have agreed upon, from Zaza's talk in the beginning of the session. And I'm maybe looking at it in the reverse or the opposite way. So again, cancer and heart failure, but looking at the increased risk of cancer in patients with already established heart failure. And these are the causes of death, and you, of course, recognize that, how does this work? Nope. Here. That cancer and heart disease are competing as the major causes of death these days, and maybe they are connected and not just mere occurrence. And when I started thinking about this, sitting in the heart failure clinic and evaluating patients before heart transplant. And as you know, patients that have cancer in the last 5 years are ruled out for transplant. And I noticed that many of my patients are being ruled out on this, for this cause. And I started thinking maybe there's something there. And if you look at the causes of death in patients with established heart failure, you can see that many of the deaths are non-cardiovascular deaths, more in the patients with preserved ejection fraction, but also in those with reduced ejection fraction here. So are cancer and heart failure linked together? And is it important? I'll try to answer these questions. And this is the paper I was lucky enough to publish in JACC. And it happened because of the help of two contributors. First, Yariv Gerber, who is an epidemiology specialist from Tel Aviv University. And second is Véronique Roger, who was the mentor, and I worked together with them. And quite quickly, within a few months, we were able to summarize this data. Utilizing this robust epidemiological project, this is the Rochester Epidemiology Project. This is the area around the Mayo Clinic for which we have epidemiology information for a decade now. And utilizing this information, we designed this project. We looked at two designs. First is a case control design. So 960 patients with heart failure, and then we matched community controls to these patients and looked at the prevalence of cancer at the time of heart failure diagnosis. Okay. Next, we excluded all the pairs that either the heart failure or the control had cancer, and we looked at the incidence of cancer. Is there more occurrence of cancer later on during follow-up? These are the characteristics, and of course, the heart failures are different from the controls. And we tried as best as we could to look at all these different variables and match them later on. And these are the results. So at the time of heart failure diagnosis, there was no difference in the prevalence of cancer. 22 to 23% had cancer. However, during follow-up, there was an increased incidence of occurring new cancers, about 70% more in the heart failure population. And this is how it looks graphically. You can see that there's a lag period. I point here. So from the time of heart failure diagnosis, it takes about a year and a half to 2 years until these graphs diverge. Later on they merge, but this is a more statistical issue with less numbers at follow-up here. We looked at the difference between time of diagnosis, earlier diagnosis before 1990 and after 1990, and most of the difference is after 1990, as you can see here. These are the cancer types, and these were all around the place. There was not one specific cancer type, digestive, male reproductive, hematologic. We could not differentiate one specific cancer type. How about the risk of death? As you know, patients with heart failure die, and they die more. So is it important to also have cancer? And the answer is yes, it is. It's important to have cancer, even if you have heart failure here. The increased risk of death is about 50% more. So this was the first publication, and there was nothing else in the literature yet about this topic. And I was very happy to see that last year in the ACC, just opposite the board where I presented, there was this Danish group that present their data. I didn't see it in a paper mode yet. Over 9,000 patients, and again an increased risk of cancer, about 40% more. But this was kind of a diverse group. This is community controls. It's very hard to look at all the contributing factors. So, and one of the critiques was that maybe there's a difference in risk factors. So we looked at this different group. This is yet unpublished data. These are all myocardial infarction survivors, and we looked at just over 1,000 patients. 21% developed heart failure, and 79 did not develop heart failure during follow-up. Again, these are the patient characteristics. Again, they differ, but not as remarkably as the previous group. And we could kind of look at the different variables and match those. Most notably, these patients with heart failure were older, and they had more Charlson comorbidity index scoring, so they were sicker, of course. So what's the association of heart failure with subsequent cancer risk? The time of diagnosis here is important. Heart failure was diagnosed early, about 3 days median after the MI, and cancer was diagnosed later, about 1,000 days after diagnosis of MI, and we had long follow-up. It's almost 5 years of follow-up. And this is the association, and it's quite similar. Look at this adjusted number here. Again, about 70% more cancer in patients with heart failure as opposed to those that did not have heart failure. And this is adjusted for age, sex, and Charlton. And if you adjust even further, you get about the same results, 95% more cancer in this group. Does it matter if it's heart failure with preserved versus reduced ejection fraction? It appears to make a difference, although we had echocardiograms only for 70% of the patients. But look at this, almost all of the difference in patients with reduced ejection fraction. Almost nothing in those with the preserved ejection fraction. And again, this is adjusted. These are the leading cancer types. Again, nothing very specific here. No difference between the groups. And this is in a graphic mode. You can see here again about 1.5 to 2 years of a lag period, and then the graphs diverge with the increased incidence of cancer in patients with heart failure. How about the risk of death? Again, if you have heart failure and you also have cancer, you have increased risk of death, 3.9 of hazard ratio. So this is, of course, the million-dollar question, and in this kind of population-based epidemiological studies are not designed to answer these questions of the possible causes. But I can make some fair assessments. Is it a detection bias? Of course, these are heart failure patients. They get more attention from the physicians, so maybe we're just finding cancer earlier. Against it is the time lag. You would assume that most of the evaluation would be done early with heart failure diagnosis and not late. And also we did some exclusion analysis and did not find this to be an important cause. How about shared risk factors? Against it is the prevalence was similar at the time of heart failure diagnosis as I showed you before. Could it be a problem with healing and regeneration or with telomere shortening? Could be, but again, the prevalence was similar at the time of diagnosis. Is it medications? Maybe. I don't have enough data, and it's almost blasphemy to say anything against ACE inhibitors or any of the heart failure medications. We need more evaluations to look at this. Radiation, it takes probably longer for radiation to cause cancer than 1 or 2 years. And this is my favorite possible cause. It probably has to do something with the heart failure physiology. Either the increased inflammation, the tissue hypoxemia, or the hormonal, neurohormonal activation that may cause some of these cancers to arise in heart failure patients. So in conclusion, prevalence of cancer in newly diagnosed heart failure patients is similar to controls. The incidence of subsequent cancer diagnosis is approximately 70% higher. Patients who develop heart failure after MI have an increased risk of cancer, and heart failure seems to precede cancer diagnosis after MI. Cancer in heart failure is associated with increased mortality. And therefore, the implication, I think, at least we should adhere to the current recommendations on cancer surveillance in our heart failure patients. Maybe we should even be more stringent. And we should try to be as holistic as we can when treating patients and heart failure patients in particular. So thank you very much.